Flora. Good evening, everyone. I too would like to introduce custodians of the lands on which we meet. I'm on Darug land myself, and I'd like to pay my respects to elders past, present and emerging. It's been many, many months since COVID-19 was declared a global health emergency. The potential for containment policies to ignite or exacerbate domestic and family violence has been widely recognised, and really as a parallel public health crisis, widespread domestic and family violence has been likened to an opportunistic infection flourishing in the conditions created by the pandemic. Today we have three experts in the field speaking to us from very different perspectives. We have the global research perspective with a focus on low and middle income countries, an Australian research perspective on health service provision, particularly in the COVID climate, and the views from Women's Safety New South Wales, a statewide peak body for women's specialist services advocating for women's safety. So to begin with, I'd like to introduce Dr. Jagnoor, who will take us through the global response to this shadow pandemic. Jagnoor is the head of injury prevention at the George Institute for Global Health, India. She is the co-director of the World Health Organization Collaborating Centre for Injury Prevention and Trauma Care. Her current research spans a number of different areas, including injury prevention, rehabilitation, health-related quality of life, economic impact, and alternate systems of insurance with respect to injury, mild traumatic brain injury, and whiplash. She is extremely passionate about creating new knowledge on the underlying determinants of injury risk through an intersectional lens. Is engaged in several projects in low and middle income countries. I'm also grateful to be able to work alongside Jagnoor at the George Institute. So over to you.
Just making sure I'm not muted. Hello, everyone. Thanks, Jan. I think when you listen to your introduction, it kind of justifies what happens through your day, and you think, okay, I'm doing something. I'm not just on in a fog or on Zoom meetings. So just to make sure, can you see my screen? Is it coming up? Yeah. Right. So just as Jan introduced, I would be talking about some of the global responses to the shadow pandemic, as interpersonal violence has been called by several researchers, advocates, and even politicians globally. Since we are as of this morning over the US election, maybe I can use the Obama quote and say it's not a virtue to pretend that you're an expert at something that you're not. So I am genuinely looking forward to learning from my fellow panelists on this webinar, because I don't think I'm an expert. I'm definitely not an expert. It's not a humbling statement. It's actually an honest statement. My background and introduction to interpersonal violence has been primarily working on burns in India. It's quite a complex issue. Burns in India are not an injury. They come across as part of the interpersonal violence, often associated with dowry deaths. That is something that we see in the society early on after marriages. It's very much stemmed from a very strong patriarchal society. So that was kind of my introduction to what I see in India in terms of interpersonal violence. And that's from where my interest grows. I would like to start with a quote from Audre Lorde. It says, "There's no such thing as a single issue struggle because we do not live single issue lives." And that kind of just reflects on that interpersonal violence doesn't exist in a small bubble. It's not a one-off event or issue. It stems from a system of oppression that we see across the life course. So many of you might already be aware, 1 in 3 women experience interpersonal violence across the globe. And as is reflected in this map over here, high-income countries have it slightly less than low-income countries. Southeast Asia region as well as the WHO Eastern Mediterranean region has one of the highest with 37%, followed very closely by the WHO Africa region. The Western Pacific region where we sit today is around 24.6 and one of the lowest in the world. Not remarkably though. So this is a bit of statistics before the pandemic. So we know that around 243 million women and girls aged between 15 and 49 experience sexual and physical violence. I believe this data comes from 2017 as per the WHO and UN policy briefs. And it talks about what are the exacerbating factors, including security, health, money worries, unemployment, cramped living conditions, isolation, movement restriction, and also even deserted public space for women. What is estimated is that there will be around 31 million additional interpersonal violence cases for the next 6 months of lockdown, and that could vary by what level of lockdowns you have globally. People have often called this as a bubble burst, perfect storm, shadow pandemic. Politicians have even called it ceasefire. An interesting term when you think that it's a ceasefire between perhaps one gender, 50% of your population against another. We have seen 40 to 50% increase in Brazil for interpersonal violence, 20 to 30% in Spain and Croatia. And similar numbers have been reported across UK, China, India, and South Africa. And in response to all these terms that have been used for interpersonal violence since COVID hit us is, pardon my Spanish now, I hope I can make some sense of it, Masculia, and 19, one of the programs that was started in Spain, Safe Words, Signals for Help. So various advocacy and education programs and outreach programs have been implemented globally for interpersonal violence response. As we speak today, South Africa holds 5 days of mourning for those lost to COVID gender-based violence, and that just reflects on how big an issue it has been in South Africa since the beginning of the pandemic. I also wanted to reflect a little bit on the intersectionality of all of this and how some of the responses are literally from the ground. So, and this news item talks about Cox's Bazar in Bangladesh, where a lot of Rohingya population is placed right now, and people and women over there have already experienced a lot of sexual violence, being in refugee camps and struggling through several other issues. What we see is that these health workers who are supposed to provide some basic immunization programs or look after child health and have various other roles and responsibilities are stepping up and providing support to survivors of gender-based violence within the camps. There have been some government-led responses, as can be seen in Uzbekistan, Turkey, and Montenegro. Sorry. Then I just wanted to reflect on, well, we know that the interpersonal violence is on the rise. There is clearly disruption of social and protective networks. And some of the things that have been asked in organizations across US and UK are, how has COVID crisis affected your ability to support survivors? And as we see, it is again a multi-sectoral issue. We see issues with shelter. We see issues with respect to reaching out to the survivors. There are challenges with food, financial, healthcare, as well as childcare. So it's definitely not a single point issue, and everyone needs to put in and come in and do their bit. However, we also see a lot of financial constraints, furloughs, and people needing to upskill themselves on a very rapid basis in some of these countries. Overall, globally, there has been a system response in terms of countries introducing new programs or upgrading existing programs against interpersonal violence. This was last updated, I believe, in May, and as you can see, there's the programs around 45 across various countries as of 20th of March, got 3 times up with 105 in April. And this, the pie diagram below reflects on some of the social assistance programs that have been going on since. I heard some of my colleagues from New Zealand reflect on how great it has been in some ways, that there were rapid fundings provided for interpersonal violence response. It did mean that there was a lot of flexibility on how those funds were being used. There was a bit of concern on accountability as the funding was being provided and perhaps still not having enough resources to implement it. But nonetheless, it was seen as an influx that enabled the entire system to respond fairly quickly to the need. Once again, I come back to the fact that there's a need for a whole of system response, and what we see as in terms of interpersonal violence as a manifestation, it's just a symptom of a much deep underlying issue. And recently, I was fortunate enough to be involved with the Global Health 50-50 initiative, one of the initiatives that looks at how global health organizations, over 200 plus, perform in terms of their governance and programmatic responses to gender. And one of the things that we were looking at this time when analyzing and extracting data for these 200 plus global organizations was how are they monitoring and evaluating their COVID response, taking gender in view, but also how organizations have come into terms with respect to their policies in supporting employees across these organizations. And unfortunately, I think out of the 200 organizations that we looked into, there were hardly 4 or 5 that had any kind of policy change that has been brought on and in response to supporting women across their organizations for COVID or even interpersonal violence. I think one of the things that we as researchers within the group were hoping that maybe it's not reflected on their websites and policies, but hopefully in their day-to-day practice, they have already implemented steps to support women in these organizations. Well, seismic shifts are needed, but until then, let's hope for some multi-sectoral action. And I just reflect on some of the things that have been put across from WHO policy brief on responding to interpersonal violence. It's what governments and policymakers can do, health facilities, health providers can do, what response can humanitarian response organizations provide, community members, and women who are expecting violence. One of the things, another thing that I found quite interesting, talking about community members, the talk that we have heard across various groups globally is that there's more and more coming across in terms of community resilience, and the need to rely on systems is somewhat decreasing. I don't know if it is a fallacy or is it actually that we have adapted and we have brought in systems, hopefully keeping them still safe, where people can find more cohesion within the communities and find safe space. Almost towards the end, I wanted to reflect on Jackson Katz's TED Talk, which I believe was from 2012. I think we can do better in terms of our discourse and our narrative around interpersonal violence. It still seems we do rely a lot on the passive construction. I hope that changes, and I hope there are a few men in the audience over here and it doesn't come across only as a women issue. Wrapping up, I wanted once again to highlight that oppression is quite intersectional. The challenges are not only gender-based. We have come across many other, unfortunately not so much great data or reporting, but clearly being highlighted through anecdotal experiences on people with disability, with socioeconomic disadvantages, rurality. I mean, the lockdown in COVID-19 across many countries did mean that people involved in labor market had to move back to their villages or place of origin where none of these services are available, and there's a lot of disruption. So just realizing that it's not only intersectional in terms of the characteristics of the person, but also time and place. IPV just remains a symptom of a much bigger issue. Context is God, and it changes massively across various settings. I think a good learning was also during tsunami from Sri Lanka, or the experiences we had during Ebola outbreak in African continent, and acknowledging that there's a lot of heterogeneity in these settings, and one size definitely does not fit all. People are experts of their own lives, and it's great if we can genuinely use this crisis for something better, and build community resilience where survivors do not feel that they are no more part of the bigger social psychological systems and support systems that they have always relied on. That's it. Thank you so much. I will stop sharing, and I hope Patricia will take it on from there.
Thank you so much, Jagnoor. That was great, and such a comprehensive picture, as comprehensive as you can be in 10 minutes. And perhaps during the discussion time, I'd love to hear perhaps some examples of how intersectionality has been done well, or perhaps what it could look like in practice. So next, I would like to introduce Dr. Patricia Cullen, presenting quite recent research on how the frontline domestic and family violence workforce in Australia have stayed connected to their clients and each other throughout the pandemic. Trish and I have spent the better part of 2020 investigating these issues within the health workforce in Australia, and it's something that we've been incredibly moved by the capacity in the space. Trish is a National Health and Medical Research Council Early Career Fellow in the School of Population Health at UNSW. She's also an honorary fellow at the George Institute and Narawan Naju First Peoples Health and Wellbeing Research Centre at the University of Wollongong. Trish's research really centres on integrating trauma-informed care in health settings and improving the health of women and young people experiencing violence in their relationships. With colleagues, Trish is exploring the sex and gender dimensions of COVID-19 on women's health, and she's currently leading research investigating the intersection of COVID-19 and family violence in Australia. Over to you, Trish.
Thanks, Jan. I'll just get my screen set up. Has that worked?
Looks great, Trish.
Okay, great. Thank you. Thank you very much for that introduction. I'd like to also acknowledge the traditional owners of the land on which we're all joining from. I'm on Dharawal country down in the Illawarra region, and I'd like to pay respects to elders past, present and emerging, and all Aboriginal and Torres Strait Islander people who have joined today. So as Jan mentioned, this is part of a larger project funded by the UNSW COVID-19 Rapid Response Fund, which aimed to investigate the sex and gender dimensions on women's health and wellbeing. And there are 3 streams in this project, and this sub-study falls within the domestic and family violence stream. And it's one of 4 studies in this stream. Jan's leading one of the other studies, which is based in emergency departments. But this study that I'm presenting today was focused on understanding the experiences of frontline domestic and family violence workers. So we conducted 50 in-depth interviews with frontline health, legal and specialist services between July and October this year. And we asked participants to reflect on the impacts of COVID-19 on their clients, on themselves as workers, and to identify what had been most effective in responding to domestic and family violence during the pandemic. So here's a bit of a snapshot of who we interviewed. So you can see that participants were spread across states, primarily drawn from the East Coast, but also we did interview a few people from WA, NT and Tasmania. Likewise, participants were drawn from a range of services across the sector. And we asked participants to identify the primary group of clients that they worked with, and there was quite a broad cross-section of client groups. Around half of the people that we spoke to were managers or team leaders, and half were team members. So there was a huge range of innovative adaptations that services and practitioners made in order to keep in contact with their communities and their clients. So today I'll just be sharing only a few of the main ones that came out of our interviews. There really was too much to share. And these main ones primarily involve shifting to outreach models of care, implementing infection control procedures, particularly in crisis and accommodation services, as well as changes to legal support and the widespread uptake of telehealth and digitally enhanced service delivery across the sector. So services described how they had to rapidly pivot, which is a very 2020 word, and then they had to sustain these new ways of working. And particularly for the people that we spoke to in Victoria, they had to sustain it for quite a long period of time. So some of the main changes that they made were changes to the hours of operation. Some services went from a 9 to 5 Monday to Friday to a 24/7 on-call operational model. And this was in order to meet increasing demand, but also to ensure that women were able to make contact at times when the perpetrator may have been asleep. So many staff described that their clients' needs really changed as soon as we went into the lockdown period, and their clients' most pressing need was typically for their basic needs. So services partnered with food banks and charities to support clients to access food, to access emergency funding for bills and heaters, blankets, whatever it was that they needed. They reconfigured spaces to comply with physical distancing and to accommodate staff through staggered hours in the office. One thing that really came out was that maintaining a sense of community was really important, and this was particularly so for the services that offered a lot of group activities or support groups. And these groups had to make substantial changes. They were no longer able to bring big groups of people together. And so what they did was either shift online, make the groups go outside, or have smaller groups. But in a number of services, they actually switched from doing group work to providing more of a case management delivery model. And there was one particular service that was a men's behaviour change group, and they shifted to, so they typically provided court mandated groups, and they shifted to providing welfare checks and case management calls, and they were calling up to 80 men a week, which was a huge change in the way that they worked. But they felt that it was hugely important because of the needs that the men were experiencing at that time, and they ended up doing quite a lot of suicide risk assessments. Crisis accommodation services were obviously considered an essential service, but since COVID-19 is an unknown threat and there were a lot of fears around contracting the virus, services felt that women were weighing up the known threat at home versus the threat of exposing themselves to the virus by entering crisis accommodation. And likewise, staff were also concerned about their own risk, and particularly for those who had chronic conditions themselves or whose family members may have. So shelters continued to operate, but with strict conditions and infection control procedures in place. Staff received formal training, but it was a huge amount of work from a policy perspective for those organisations to stay on top of the changing public health orders. They provided sanitation packs and some actually, I think the quote I put there, yeah, they had a dishwasher installed. They hadn't had a dishwasher before. And so things like that made a really huge difference, not only during the pandemic, but for the future as well. There are lots of adjustments that were made to the processes for attending courts and shifts to phone and online delivery of legal support, which was challenging. There were mixed perspectives on how well some of these changes were implemented and who they worked well for. Applications for apprehended domestic violence orders shifted online, which many felt were fantastic, but it does require a degree of literacy as well as digital literacy. So there were some issues around that as well. And I won't go into too much detail on this because I think we're going to hear from Hayley next, and she can provide much more insight into this, which I'm looking forward to. So the big shift, not only in the sector but everywhere, was to telehealth and digitally enabled service delivery. This enabled services to remain connected with clients. It kept staff and clients safe in terms of social distancing, and overwhelmingly services saw the value for their organisation of being able to continue to provide digital support, and they saw it as a really promising long-term adaptation that they wanted to maintain. Some people felt that it removed a lot of access barriers for many clients. But on the other hand, many people we spoke with identified concerns about the shortcomings and the risks that are associated with telehealth. And while they felt that their service had done well to keep connected with clients, they'd done what they needed to do, they also felt that there was a lot to consider about how this could and should be done in the long term. And the main issues tended to centre around privacy and confidentiality, both for the client and for the staff, who need to be able to access a private space, which can be challenging in a remote working situation. But there are also risks for those involved, particularly for women whose partners may monitor their phone, and also in terms of children who may be present. So some services opted to not use the video platform and to just use the telephone, because in that way they can only hear what's being said in front of them rather than the full conversation. And staff also felt that there was some risks for them using the video platform if the perpetrator was able to see who they were, so risks of exposing the identity of the staff member. And even though there was improved access for some clients, there were definitely issues around who was not readily able to access telehealth or digital options. For example, there was concern that clients who are in crisis are not in the right frame of mind to be able to learn new systems, and people felt that the telehealth was overwhelming for some clients. So we talked to staff about some of the challenges that they'd faced, and we wanted to know what had worked well and what they wanted to see more of in the future. And I think this particular quote sums up quite well what a lot of people said. It was the bringing of the work into their home environment was quite challenging. When you're talking about it and you're hearing and you're exposed to it in the office, you leave it at the office and it's much easier to separate. This was pretty much the major issue that people identified. So the people that we spoke with are clearly already working on the front line of the domestic and family violence epidemic that we have in Australia, but then they were suddenly thrust into this new realm of being an essential worker, which was a new 2020 term as well. So people talked a lot about the realities of being an essential worker when, you know, they'd never signed up to be what's now classed as an essential worker. And it was quite confronting, simultaneously working in domestic and family violence, which was amplified during the pandemic, but also being on the front lines of the pandemic. The workload was an issue for people. There's already in the sector, it's a very demanding workload, and there's often many additional hours of unpaid work. And many people felt that these pressures had really increased substantially, particularly with little separation between home and work life. So that collision between work and home, when people were working remotely, people felt there was a breaking down of the boundaries between the work that they were doing and being able to interact with their housemates or their family. And I think this quote illustrates it quite well here, like just the actual practicalities of trying to do this work when you've got children learning at home. It would have been very, very challenging. So the other big challenge that people identified, not surprisingly, is the risk and the reality of vicarious trauma. So there's always the risk of vicarious trauma for those responding to domestic and family violence. However, people felt this was really amplified when working remotely, with less access to colleagues to debrief, less separation from work, and also because the measures that organisations would typically put in place to protect workers are constrained when people are working from home. And I think this quote really describes the reality for many people that we spoke with. Because I'm doing it here, it's like it's in my house. The violence is in my house because I'm speaking and I'm hearing it and I'm trying to manage it in my home at my dining table. So it just feels like it's here all the time. We heard so many variations on that. It was really distressing for people. Many people spoke about their worries for the future, both for themselves, their colleagues, but mostly for their clients. In terms of themselves, people sometimes spoke about the realities of insecure funding and short-term contracts. There was a sense of, not that people described feeling burnout, but this kind of sense that how long can we keep this pace up for? And there was a fear of burnout in the face of new ways of working. But the main thing that people were worried about was who they were not seeing. So people felt really genuinely that they were doing well and working well with the clients that were able to make contact with, but it was a sense that many of their clients had not been able to make contact, and they worried for them, and they worried about what was to come for them. And this quote, I mean, as we all know, we're focusing on this pandemic, but the real pandemic's been there forever and it's not getting any better. And I think that Jagnoor summed that up really well in terms of from a global perspective too. So what worked well? People talked a lot about what worked well. There was a lot of pride in how services had adapted and a lot of excitement for new ways of working and what could be taken forward. The big thing that was valued by staff was keeping connected with their colleagues, the opportunity for additional formal supervision and opportunities to informally debrief with their colleagues. People enjoyed the flexible work that allowed them to balance care and family responsibilities. So even though it was challenging to do it in a home environment, they did see the benefits of having that flexibility. And then some workplaces introduced wellbeing initiatives, so like social Zoom get-togethers or quizzes, group yoga, and just giving staff extra time off in acknowledgement of all the extra work and pressure that they were under. In the new normal, people want to see flexible working, including a blend of working from home and working on site. They'd like this integrated into their regular practice. People would like to see more online meetings. People loved that they no longer had to travel to meetings and that they could just click into meetings, so simply. But they also wanted support for ongoing wellbeing initiatives and online meetings with colleagues from other services. So this was another big one that came out about connectivity and collaboration. So initially that there was some challenges around that. No one knew exactly what other services were doing, but once things sort of got underway, people felt that there was increased opportunities for collaboration with online meetings. And I think that this quote, this is the final quote that I'm going to share, but I think this is a really good example. This was a practitioner who had felt quite sort of isolated in this aspect of their practice, and being able to connect with colleagues who provide medical termination. So it's a very sort of niche area. It probably wouldn't have happened if the world hadn't turned Zoom crazy. So now we're going to try and do that every couple of months. So I'd like to acknowledge the project team who've done so much work on this. We did 50 interviews in sort of the space of 2 or 3 months, and we just had such an overwhelming response from the sector, which was amazing. So Rachel Bafsky, Kristen Beek and Sarah Wayland. I'd also like to acknowledge the investigators of the Rapid Response Grant, the funding from UNSW, but most importantly, the 50 men and women who shared their stories with our research team. We're so grateful. Thank you.
Thanks so much, Trish. That was wonderful, and I think a great discussion at the end. It leads really well into our third panelist for today. I'd like to introduce Hayley Foster, who will be presenting critical feedback from the Australian sector on COVID-19 and domestic and family violence responses. Hayley is the CEO of Women's Safety New South Wales. She holds advisory positions on the Australian Women Against Violence Alliance and the Australian National Research Organisation for Women's Safety. Hayley's experience in the space really knows no bounds. She has over 15 years experience in frontline specialist women and children's services, violence prevention, accredited men's behaviour change, family law practice, family dispute resolution, policy law reform, advocacy, sector development and organisational management. She's passionate about the work of women's specialist services and about having diverse women's voices represented in addressing gender inequality and gender-based violence. And on that note, Hayley will be joined by Nadine Taylor today. Nadine is a registered nurse and also the founder of Hope and Heal, which is a wonderful group of talented professionals with a common purpose to relieve the suffering of women who have experienced family violence through meditation and mindfulness and self-care and awareness. So very grateful to have both of you speak to us and to be able to learn from you both. Over to you, Hayley.
Thanks, Jen. Thanks so much. And thanks for the fantastic presentations so far, Jagnoor and Trish. It's just really, really wonderful, and I can absolutely say that it's very, very reflective of our experience. Couldn't have, and you covered a heck of a lot in a short period. So thank you so much for that. I'm coming to you from Gadigal country in the Eora Nation, and I too pay my respects to elders past, present and emerging, and extend that respect to all Aboriginal women and people who are joining us today. I've had the great privilege of working alongside some amazing Aboriginal women and community in this work and in my journey so far, and it's always ever present for me in front of mind to think about the fact that many of our First Nations women and community are not only battling violence behind closed doors, but also throughout institutions in our community as well. And Nadine, if you'd like to just say hello, it's so fantastic. Thank you so much for taking the time to join us today. We're absolutely thrilled to have you. If you just wanted to maybe say a couple of words. Oh, you're on mute.
Can you hear me now?
Yes, lovely.
No, thank you very much for giving me the opportunity to speak today. Yeah, as a nurse working on the front line and also with the charity that I run, pretty much what I've heard today is what we've been finding. People have been reaching out, they've lost that connection, that community, that support. So yeah, it's very interesting. Thank you for inviting me to be part of this.
Wonderful, thanks so much. I thought it was really great to have Nadine's perspective, because when we were talking about having this forum, a lot of our conversations were centred around the intersections between domestic and family violence service responses and health responses, and just the fact that at the moment it does seem like it's quite siloed, our domestic violence response and our health response, and Nadine's on the front line with that as a registered nurse, and able to speak to that from personal experience. And so I think it's really great to hear directly from those who have that that frontline knowledge and experience. I thought it looks like I'm going to be sharing my screen, so I'm just going to try that now, and hopefully that will work. Can everybody see my screen there?
Mm-hmm.
Okay, lovely. So we only have 10 minutes, and we've probably taken a couple in introducing ourselves. So I might not focus on the key issues facing service providers, because that was already beautifully covered by Trish. I might just go straight into talking about the experiences for clients on the front line. We've heard both from service providers and also from women who have been experiencing violence throughout this time and abuse throughout this time as well. So I'd like to just spend our time sharing some of those insights with you. As we've been introduced, we're a statewide peak body for women's specialist services, particularly representing the women's domestic violence court advocacy services that support over 50,000 women each year on close to 250,000 occasions through after a police incident, but they can take referrals from other agencies such as health, although that referral pathway has not been really dramatically opened up in the way that we'd like to see it, and from a range of agencies and self-referral. They also support women through the court system in 136 local courts across New South Wales, and also in the family courts through the Family Advocacy Support Service in the major family law registries. So they've had a fairly good insight and purview into what women and their children have been experiencing through the pandemic, this journey. So I've already talked about what our purpose is. We basically are a big microphone for our members. We constantly closely consult with them and hear from them what are the issues. We consult with them on particular issues that they've raised or that are being raised with us, and then we are their conduit to speak to policymakers, to government, and also to have a public conversation. We're very transparent, and we like to work with government, but also include the community more broadly through media and other public channels to make sure that we're all, I guess, prioritising reform in this area and not resting on our laurels. So as you can see here, so we undertook several surveys throughout the pandemic in March, and then again in April, and then again in May. And the last one we did was in August. And we also undertook specific we also did specific surveys with our Aboriginal specialist workers across the state, and we've got one of those now in each of the 27 services, and also our multicultural specialist workers. And then we did a few specific ones on, families that were separated and experiencing an escalation in risk in the context of separated families and family law and child protection and child custody issues, etc. We also undertook a particular study into the issues around interpreter services. And yeah, so there was a range, alcohol misuse as well, and the links. So there were a range of studies we did. We consulted very closely, and then we shared all of those findings. What I'm sharing with you today is pretty much an overview of some of the key things because of just the sake of time. So as you can see there, since the outbreak of COVID, 40% had, and this was during the pandemic. So we've updated these now since the pandemic, since the restrictions have reduced, the COVID restrictions, and now we're actually seeing still an increase. So 45% are saying there's an increase even since the closing of those, the reduction of those restrictions or the easing of them. And we're still seeing an increase in the complexity. So 70% at the time said there was an increase in the complexity of client matters and presentations. Again, that's gone up to 80% since the COVID restrictions have been eased because of the economic impacts that are being cited. So that's quite interesting. So the key issues facing clients were that there was an insufficient service availability. So whilst a lot of services were pivoting, as Trish was alluding to, there was a real, there were many services that weren't accessible, and one kind of key example would that be around court. So the fact that courts had closed down, in terms of their operations, they were telling women not to turn up to court. Many of the women that are supported through our membership would be usually, we would contact them proactively after a police incident, or and then when they were going to go to court, we would go and meet them there. And if there were women that we didn't have the contact details of because the police hadn't obtained them, or because it wasn't safe for them to pick up the phone, which was an issue we found had been exacerbated during lockdown, then often in the past we might see them when they turn up to court. Unfortunately, this avenue was closed to us, and we were experiencing what Trish was describing around a real concern, quite a big concern about the women that were falling between the cracks during that time. You can also see a lot of the commentary reflected from Tricia's presentation about women prioritising material needs and concerns over their own safety, escalation and worsening of violence, and we saw that picked up by the Australian Institute of Criminology study, and violence abuse for the first time, as well as violence and abuse particularly related to COVID. So one of the really important initiatives that we had been involved in is through the development of the urgent COVID list in the family courts, to be able to provide access to an online nationwide standardised list in the family court that could hear matters urgently within 72 hours of assessment. So they're the sorts of things that we were trying to innovate on during that time. I won't talk about the key issues facing services. Trish covered that extremely well. So there were a lot of, it was a really big toll. And I have to say, for our members, they were also, many of them are coming off the backs of the most horrendous bushfires, which were really quite traumatic and overwhelming. And then they also had to go through a commissioning and retendering process for their very own ongoing service and their employment. And we lost a number of workers who had just been absolutely incredible due to that restructure. And of course, there were important reforms as part of that recommissioning and tendering process. But I think the impact that, the layering of the impact there cannot be overstated. I might skip that because it was covered so well and just for the sake of time. I might just also talk about some of the economic impacts that we're seeing now. So of course, there's the particular experience of women during COVID, and what many of them, I mean, it was very, very difficult for them to access support, very, very difficult to reach out and call for help. One of the things you'll see down at the bottom of that slide is that victim survivors themselves, as well as frontline workers, unanimously, practically, I think there was, just a couple in our survey that we're not sure, but it's a unanimous, really close to response that we want to be able to call the police urgently and silently without the abuser knowing. And that was something that had, was really called for, and unfortunately didn't come through. Another recommendation that we had asked for straight off the bat was actually to increase the capacity of web chat services, because I think a lot of the issues that Trish was talking about earlier around clients having, everything going online, but then security and privacy and safety being a consideration. Online web chat with exit functions and no ability for those communications to be traced are incredibly important for safety, and also for accessibility, but particularly for some certain cohorts. So I think, that was something that we had pushed for. Unfortunately, again, there was not a lot of support for doing that in an urgent way. They're looking into it now, but so for in the future, but during the pandemic, unfortunately, that was not something that was available to us. Look, so I think in terms of what we're seeing in the economic impacts, I've talked about how there's an increase in complexity, higher risk cases. We have services now that have a 95% increase in their serious threat matters at the same time this year compared to last year at the same time. And right across the board, I've been having forums with my multicultural members and my Aboriginal members, and then the broader membership. Right across the board, we're seeing an increase in the severity and the complexity of cases, many more threats on people's lives, much more use of weapons, more strangulation, more severe physical violence, but also extreme levels of coercive control. So that is something that we're contending with, and the service is absolutely a very, very accurate representation of where the service is now. Everyone's extremely exhausted. They're just limping towards the end of the year, but also anxious, because we know that there's always an increase in demand, an increase in violence and abuse being experienced over the Christmas New Year period. And then after that, all of the, the actual service demand rises after that period. We know women will often deprioritise their safety during that time. They may not reach out for help until afterwards, but there will be an absolute onslaught, and there will be serious incidents over the summer period. And it's a terrible thing to be able to state that with fact with such certainty. So I guess they're the kinds of things. Mindful of time, I'd love some time for discussion, because I think it'd be interesting to hear from Nadine and others around the health intersections. We've been very, very encouraging of some of the reforms coming our way through the health service system in their response to domestic and family violence. But with frankness, we need to hurry up. So I think it'd be really great to have some good conversations about that. I will mention quickly there, you can see economic impacts. And really it's about financial, there's stress, there's triggers, there's increase in alcohol misuse, people having impacts in terms of their employment, and that is exacerbating, that is throwing fuel on the fire, so to speak. We know it's not the cause, but very much certainly a contributor. But on the flip side, a really big issue, and this was touched on by Jagnoor in her first presentation, is about access to services. It's about like the actual, ability to live sustainably, the lack of affordable accommodation that's available, the lack of case management support to support women through that process, and some of those macro settings in our economic portfolio really start to become important, and they've been picked up by frontline workers. We need to make sure through the JobKeeper, JobSeeker, coronavirus supplements, we need to make sure that people have access to income. And a particular shout out for our clients who are women on temporary visas who have a limited access or restricted access to working rights and also essential government services during this time. But we need to make sure that across the board we have access to affordable accommodation, access to income, and access to support people through what is can be the most traumatic parts of experiences that they've had. And so I think all of those areas that we will continue to advocate on. But I guess oh, and one other thing I must mention, even though I am over time, I believe, is just policing. It was a really big concern because police resources were very much taken off their regular duties to go to kind of address COVID-related issues. They were redeployed, many of them, and on rotation. And we were extremely concerned that a lot of the specialist domestic violence police were being taken off their duties, and that reduced the services available and the specialisation of those services, the police services that were available, and issues that we'd already had with police were blown out of, they were blown out of the water. They were completely exacerbated. Issues like, and the focus of corrective services and the courts to keep as many people out of custody as possible and supervise them in the community. But the breakdown in communication, so the victims themselves and their advocates were not advised or consulted around bail and around conditions. That's exacerbated risk as well. But also some of those old chestnuts around police not including children as protected persons on their protection orders, the misidentification of the primary victim and primary aggressor in a matter. And just a lack of willingness to respond effectively and really vigilantly to breaches of domestic and family violence orders. I will leave it there for now, but I do hope we can have some interesting conversations together.
Thanks, Hayley. Nadine, before I hand over to you, Gabrielle, I just wanted to check whether we could spare 5 or even 10 minutes to really make use of the expertise on the panel through some discussion. Would that be okay?
Absolutely fine with me. Thank you, Jan. And just a reminder to anybody who does have to go at 6 o'clock on the dot, this is being recorded and we'll send it to you after the presentation.
Thanks, Gabrielle. Over to you, Nadine.
Hi, thank you. I just think from a survivor's perspective and also from a nurse working in the hospital, I do have big concerns at the lack of knowledge on what constitutes domestic violence and the lack of education for managers. This is something that Hayley knows well, that I've been advocating for a long, long time. At the hospital where I work, we had a woman that was murdered in the hospital grounds, a co-worker. And even with this happening, it still didn't result in management and HR bringing in training for staff and managers. They still do not know what domestic violence is. They do not know what the domestic violence award is. And, I've actually had one person, apparently in the whole of the hospital, there's only been 2 women ever that have accessed to domestic violence leave, and both of them had a battle. Obviously there's confidentiality involved. The first person was refused it, was bullied by 3 managers, had to go through their union to access domestic violence leave, and another person I actually helped access domestic violence leave. And again, the managers did not know what it was. I had to help her access it, and she was also concerned that it was going to be put on her roster so that people would be made aware that she was actually accessing domestic violence leave. So I've had many, many discussions with HR and with management, and COVID is just obviously exacerbating the situation. We know the statistics, 1 in 4, the majority of staff that work at hospitals are women. So, you can't say that in all the years there's only ever been 2 women that have experienced domestic violence in that hospital. So there's a complete lack of knowledge. There is a lot of judgment for women that have been through domestic violence still in the hospital. So from my perspective as a survivor and as a nurse and as an advocate, unless we look after our own staff, then how are we going to look after the patients or people that are experiencing domestic violence? There's just a complete lack of knowledge, and you know, there is training is available, but the hospital will not give their staff half a day training, or their managers to have half a day training to learn about domestic violence, to learn about domestic violence leave. So for me, it's, you know, they're worried about money and worried about, you know, staff having half a day, but we need to look at the bigger picture. You know, it's costing the health service a lot more money. Staff are taking sick leave because they can't go to their management and you know, ask for domestic violence leave. So this is a huge issue, and one that management and HR are not willing to address. And I think given the COVID crisis, where things are, you know, are exacerbated, people are working from home. There are nurses that are actually out of work. So the, you know, the economic issues that come with that, it's huge. And I think, you know, this is a prime time. You know, the hospitals, we're quieter than we've been because, you know, thankfully we've not been hit with the COVID pandemic, and this is a prime opportunity for managers to get training or to understand, because, you know, we are on the front line. You know, people do come in, and if you get that person who makes a disclosure, you may only have one opportunity ever in their lifetime to react to that disclosure, because if it's treated badly or that person's dismissed, they will not reach out for help again. And I know that from personal experience. So I think, you know, we really need to push for management and health service to acknowledge domestic violence, to understand what domestic violence is, the different behaviours that constitute domestic violence, and also the judgment that comes with it, you know, that is happening in the hospital. You know, if someone does go for domestic violence leave, the person that I knew that was the first woman to ever go for domestic violence leave in the hospital, they'd never had to deal with a woman like, and this was a woman that was disclosing, that was having to go to court hearings, that had AVOs, that had documented evidence. So, you know, the way that managers, because it was escalated, is just appalling, and it should not be happening in this day and age.
Thank you so much for that, Nadine. I think it's a really, really incredibly important point that services are not going to be able to provide safe and accessible services and advocacy for people who are experiencing violence as clients, as patients, if they're not au fait, if they're not across these issues and treating their own staff with that you know, expertise and specialisation. And so, no, I think that's a really, really important insight, and I do hope that advocacy continues, and certainly we will be continuing to advocate alongside you in that as well. Thank you.
Thank you both. Thank you, Hayley and Nadine. I did want to open up to see if there are any questions, and there can be from you, Jagnoor and Trish, and Hayley and Nadine.
I don't have a question just yet, but I completely agree with what you've just said, Nadine. Another aspect of my research is around interviewing women and survivors of domestic and family violence about their experiences accessing support through services. And the services that get the worst rap are the police, which isn't a big surprise, but the other one is GPs and hospitals. And it's exactly what you've described. It's a lack of awareness, it's a lack of training. And we're not talking about sort of, you know, trauma-informed training or practice. We're talking about just basic understanding of what is domestic and family violence and basic ways of responding to women when they disclose. You know, there's this, I've talked to so many women who the first few times they talk about this with a GP, they get sent to mental health counselling. They get set up on an enhanced primary care plan and given mental health counselling. And, you know, that's helpful in some aspects, but it's not the full picture, and it's really disregarding their actual, it's invalidating their experience. They don't have a mental health condition, they have an abusive partner.
That's a fantastic point.
Yeah, very good point.
Nadine, having spent a bit of time now within emergency departments this year, I wanted to ask, why is domestic and family violence treated so differently to, say, a heart attack or other conditions where resources open up, on-call staff? We've spoken to hospitals that don't have a social worker at all. in areas where rates are so high and there's such a need for services. So I just wanted to ask you that question.
I think we're still having to change people's judgment, and people don't understand. I think it's a lack of education as to what constitutes domestic violence. There is still victim blaming, like, why doesn't she leave? I wouldn't put up with that, you know. And this is what we're seeing. And I think until we educate people on coercive control, and what is domestic violence, we're not going to see a change in attitude. And I think, you know, it has to start with management. You know, they have to be trained and understand what domestic violence is, and it needs to be, all staff need to basically be trained. This is a pandemic. This is, as was mentioned earlier, this is a pandemic, and it's not getting any better. So we need to educate people more. And I think, you know, hospitals are often a first point of call for people to come into hospital or to speak to someone, and they're getting judged or dismissed, and that's a big problem. So I think, you know, there are no referral pathways. The woman that I spoke that got murdered in the hospital grounds, she had disclosed to a colleague that she was experiencing abuse. The red flags were there. She was being stalked, she'd been strangled, she was leaving her partner. It was, you know, the lights were just flashing. But there were no referral pathways. There was no one that her colleague could go to speak to, and it was just dismissed. Oh, it's, you know, it's just, you know, it's a family matter. Just, you know, let's not get involved. And that needs to change. That is what really needs to change. And it starts with education, is what I believe, and changing people's preconceived ideas and judgment.
Thanks so much for that, Nadina. Thanks for the question, Jan. I guess I would really like to just add in there that it's the same thing with what we're dealing with police. And you mentioned, Trish, that was the number one complaint about a service. The number one service that was complained about was police. What we've been trying to advocate with police on, and they're a little bit receptive from perhaps a half-day training to start, is for all frontline officers, everyone across the board, but, you know, frontline officers are not getting this, and it's critical for that first, as we all know, that first response around a disclosure is critically important. But for the training, not just to be based on technical skills, but also knowledge, but also to be based to be focused on culture and attitudes, and also managing vicarious trauma. So I think, you know, vicarious trauma, we're all going to experience it if you're dealing with this work on a day-to-day basis. But it's about how you manage that, and having, you know, and there's very little, if any, resources or support or training going into that within policing and within health services as well. So I think, I guess, my only point that I would like to add to that is that across the board, we need to see, as part of our training, you know, training that really focuses on that culture and that attitudes of like those drivers and those root causes of violence against women. And, you know, without that, we're not going to get cultural change.
Thank you both for that. We've got a minute left. I promise a minute. Are there any other comments or questions that you wanted to? Nadine, over to you.
Yeah, I mean, we do, when we, you know, Hayley would know more about this than me, but when you do simple risk assessments, you know, the red flags, if a woman's, you know, been strangled, on these simple risk assessments, that this is what I would ideally like to see in an emergency department, or where someone's been assaulted, so that we can do a risk assessment. And, you know, ideally we would have an experienced social worker or nurse that's experiencing domestic violence, that these people could be referred to, and they could pick up on these cases. We just need a system in place that could pick up these things. It can be simplified, and to be taught. Someone, you know, a domestic violence social worker or a worker that's based in the hospital, that, you know, that understands what domestic violence is, can educate staff on the job, that can pick up and do these referrals and these assessments that picks up on the risk factors. It's something that can be done and could be implemented if people would listen, or managers would listen and implement something that could be simple but so effective. Yeah.
I think, Nadine, that, you know, the issue is that within health, we know that some of those reforms are in the pipeline, but they've been in the pipeline for a very long time. I mean, the domestic violence policy hasn't been updated since 2006. I remember I was working in police, health, in a health role in 2012, and recommending a lot of these things be implemented, just the basics of communication referral, and the risk screening in those areas. It does seem like a very urgent reform that needs to take priority. And when we've seen such success with referrals after a police incident, seeing, close to 250 referrals, 1,000 referrals from police in New South Wales as a result of a system like that. You can imagine if we actually open that up to health, how many more women would be able to access those critical supports. And I guess really importantly, because many women don't feel safe or comfortable or want to access a criminal justice response. They don't want to call the police. They want to access a health service, and they should be empowered to be able to do that and to choose their own journey. But we're not providing access to specialist services through those pathways. So thank you so much. It's been fantastic to have your contributions to Nadine. That made it much more interesting from our perspective too. So and thank you. I'll pass that back to you now, Jan.
Thank you. I echo Hayley's words. It's been great to have this panel, and I do think, one of the underlying messages from today has been, we're coming at this issue from such different spaces and fields and backgrounds, but there's so much that we can sort of accomplish together by speaking the same language and breaking down those silos with the resources that we have. So thank you so much to the panelists for taking the time to speak to us today. Before you go, I did want to mention that all of the videos from this seminar and the previous two will be online on the Australian Human Rights Institute website. And so we will be able to sort of shift this conversation to a broader audience as well that way. So when that comes up, you'll certainly be notified. Thank you so much. Enjoy your evenings, everyone.